Welcome from Mount Sinai Cath Lab, and we are ready for this great show. Let me start with the slide. So you go back, please. So this is done in collaboration with CCC Live and with CME Mediquest. So these are our disclosures, and then of course both Dr. Arindam Pandey and Abhishek Roy from Kolkata will be the part as individually. First, Dr. Arindam Pandey is a senior consultant interventional cardiologist, Department of Cardiology at Mediquest Super Specialty Hospital, Kolkata. And of course, I have interacted with Dr. Pandey and very experienced, as you can see here, and multiple academically, multiple papers, part of the numerous interventional trials in India, and member of the multiple societies, and so an expert in interventionalist. And then he's our faculty. Then Abhishek Roy is our moderator, also from Mediquest Super Specialty Hospital in Kolkata, interventional cardiologist, and record through his academic days. He completed MBBS followed by MD in internal medicine, and then Narayana Health, and then now basically working at Mediquest Super Specialty Hospital in Kolkata. Also, very expert technical wise, and authored many papers, and clearly growing up, and we'll have a time to interact with both of you. So Dr. Pandey and Dr. Roy, welcome from myself and Dr. Keeney and our cath lab. So today our goal is to show this PCI of the left main, calcific left main bifurcation with imaging guided, and then we will show the case of the LMCA bailout for a broken stent, and we have the interactive panel discussion. This is the episode number 26. So this is just over 2 years. We have been working with Mediquest, 65-year-old male, presented with class 2 angina and dyspnea. Patient has positive ctFFR of left main and proximal LAD at 0.72. Risk factors shown there. Mild symptoms, so SAQ score 73, score of 100 is minimal symptoms, 0 is severe symptoms, and mild diffuse LV dysfunction, whether because of hypertension or question about little alcohol. Medications are shown there. Good dual anti-ischemic therapy, and cath was done about 10 days ago by Dr. Keeney, and showed two vessel and left main disease with a calcific bifurcation, and imaging at the same time showed significant lumen obstruction of all left main, LAD, and circumflex. So maybe Anu can show, and there is a little bit of osteal disease of the LAD also. So plan today is imaging guided PCI of the left main, LAD, and circ bifurcation, and knowing that we knew angiographically also quite calcified, and imaging we have done also, which will show here that because of the severe calcium, angiographically as well as by imaging, perform the rotational atherectomy and then Mediquest technique. So just come back to the appropriateness point of view. This is a non-diabetic patient with intermediate or high risk finding, and clearly a syntax score of about 24. So the question is whether 24 should get heart team discussion or not. We usually avoid it till we get to a little higher level of 32 and above, and we know that part of the Excel trial showed, although it does not make the guidelines. But recommendation of the heart team, STS risk score, syntax score, all those need to be done, and patient has 24 STS score of 1.2, so very low risk for surgery also. STS is more for surgery, cabbage, and syntax is more for interventionalist. So overall is a low risk case. And then question down to what technique we should be using, simple left main or complex left main. This case going to be the complex left main, where both branches are more than 50% and severely calcified. So this is a kind of case people may say, well, do your stent crossover or do a two-stent approach, and we usually prefer, and that's what we have been teaching all the time, using a two-stent approach. So with that note, I'll stop here. Let's show the angiogram.
So EF you already mentioned, right?
Yeah, mild around 50%, yeah.
So antro apex slightly down, mild. RCA?
Non-obstructive, yeah.
Non-obstructive 30-50, but now ostial left main has disease. I want to show you in the way that it's a lot of damping. But this, if you see here, without any dye, just dry cine, what we call, you see tram track calcium from left main to LAD, and even the ostial circ is involved. Significant calcific disease, and this is where we are. And why we know left main is involved? Once we engage with the guide,
show that
you can show the hemodynamics.
And show the hemodynamic also. There is a ventriculization, right?
Yeah, yeah. If you can see this, this is just. But I
no,
have
but they have to show the hemodynamics.
Show the just in the side, not the whole thing.
Yeah. Now see that ventriculization. So that's basically because why it is important. We all know that even if there is a very little
in the side,
that there is very little left main, 20-30%. You should bring your stent back up to the ostium. So that becomes very important. Now, a lot of people go to ostium anyway, but if there is absolutely no disease at the ostium, we try not to come to the ostium, because anytime to cover ostium, you have to come 1 millimeter outside, 1 or 2 millimeters. So key is, unless there is a little disease, like in this case, there's almost 20-30% angiographic, and we saw that ventriculization, we will basically, in this particular case, definitely will come up to the ostium. Yeah. Yeah.
He did it. He did it.
Yeah. So you see that. Any comments from both Pandey, Dr. Pandey and Roy? Or Abhishek?
Sir, just you mentioned you did FFR of left main. So audience would like to have.
Yeah, you did FFR
how
also.
You
both.
FFR in left main. What are the techniques you applied for doing? Because probably the lesion was at ostium.
Yeah.
So how you're going to do the FFR?
No, so very good point. So question was we are doing, yeah. So question basically was that I can tell you, no matter what calculation people do, even for Excel trial, we had it that once you have a bifurcation left main, if there is a question, you do IVUS, not the FFR, because it's always difficult. Because if there is additional disease, if there is additional disease in the LAD, like in this case, there is 80%, there is no way you can figure out what is left main component, what is the LAD. So this case, we just did because to confirm, basically because of the ctFFR, which was done in this particular case, which was positive and similar invasive, because we are doing correlating ctFFR with the invasive FFR is the same number. Usually we stop after less than 0.8, but this kind of case, we do many cases we are trying to correlate, and it turns out to be there is a very good correlation of ctFFR with our FFR, particularly in the proximal to mid vessel. And remember, ctFFR becomes very positive sometimes distally, because of the diffuse disease. So that's a different story, and we tried not to be, but key, the proximal to mid has a very good correlation. Okay. And then we did the IVUS, and right here you can see that IVUS catheter does not go from the significant lesion of the LAD. That's okay.
Okay, start here.
So that basically, yeah.
Yeah, start from the region.
Yeah.
Yeah, feedback start. Yeah, this is a little bit calcium, and yeah. Did not close the region. Sorry, this is a dark image. Yeah, now we can see. And looks like fibrous plaque. This is a ostial left main. Yeah, I stop here.
Yeah, I agree. Ostium is significantly diseased. It will be definitely more than 60% and 70%. I think significant disease in the ostium.
So we have ready 1.75 rotabar. Question is, can you do with the IVL? Yes, I mean that's the biggest question. And more importantly, coming next in 2 weeks, the orbital atherectomy will be available in India, and will be starting, knowing that the first journey of orbital is started in India back in 2005-06 with the Orbit 1 trial, 50 cases done in India. First in men were done there, but now after 15-17 years, it's coming back. So the question is, can you do IVL? I think that's reasonable also, because it's a lesion. Only question is whether the IVL will cross the LAD lesion. Remember, IVUS didn't cross it. So you have to use some kind of a balloon or modifying technique before you can advance your IVL. So that will be the only limitation in this particular case. Okay. Yeah.
So if I'm allowed to make a comment, so IVL,
Yeah,
if
of
you're
course.
using IVL, ideally then the size of LED and left main is quite disproportionate. So ideally you should use couple of balloon, not one balloon. You should use one balloon for LED, one balloon for left main, because otherwise 1:1 this thing will not be there.
That is correct. Yes. Okay. And
Okay, so we're ready to start the rotational atherectomy. We have 175 bar ready. So actually when this was a significant calcific lesion length about 15 millimeters or so, now over 95% lesion, in that case, we did not do direct wiring. We used over the wire, fine crossed with the fielder wire and then changed to rota.
okay.
Now we are going
speed
up.
check.
Yeah, go. Good, 155.
So it's always set at 155.
You know, I haven't stopped, right, with Rota Pro.
Yeah.
It's always
Because the
bar
point
good.
is, actually the Rota Pro, the speed is all set at
pull the wire back.
155. You don't even have to check outside.
Pull back.
Telling people don't have to check, because this Rota Pro we have done quite a well. The set, this is the Rota Pro 2, that's what is in India now. And after next year, they all will disappear. That's the only one will be available, no longer classical Rota. Whatever we have, we can use it, although there is a big difference of the cost wise, but it will be about the same. The orbital cost will be around about 2 lakh rupees, and same is this Rota Pro. So cost definitely, and of course we know the IVL is 3. So push and pull over the wire, and here ostium probably would not make any difference.
But anyway, let's try.
Yeah. Let's
So
put the
we're going
wire
to
a little
start,
bit.
we'll start by the ostium, which means I want to start the bar right from the guide. You see that? So the bar is outside. How we know the guide is outside? We know that because we don't have any more damping, and bar is sitting just right there. So we do our 3 steps, which is here on the knob, move backward, forward. All the tension between the Teflon sheath and the bar is gone. Then I will go to the Y connector and just move the bar backward, forward. Any tension between the bar and wire is gone. And the last is on the dyna, you see the green light. Just tap it. So there's no movement of the bar.
Yeah.
So we know any kind of tension that was there, and if at all there is there should be no bar jumping. So we're going to start the rota. We're starting from outside. Now I'm in the LED lesion.
Don't go.
Okay.
So 20 second, also keep eye on the blood pressure. The systolic doesn't go beyond less than 100. If it is, then you have to give a little neosynephrine or anything we want to have, dopamine or so. But usually neosynephrine.
So second time when I'm going, I go to the spot where I actually stopped, and from there I'm advancing again. You see my fingers, they are just pecking motion. This is the tightest area. Good.
The slow advancement, packing motion, and that is the way. And hold the hand as you see on the guide catheter, but not pushing it, just holding it.
This is the polishing run. Okay, I think we're good.
Yeah.
So we'll come out now. Meanwhile,
Same Dana glide, and we can ask our audience any questions in the chat. The question now comes is the circumflex. Do we use a modifying a balloon, modified balloon of the scoring, cutting balloon, or just a high pressure balloon, or do a rota? So IVUS was done earlier, and it was less than 2 quadrant calcium. So let's take a picture and we go to the caudal view, and let's take this opinion that how do we
has
take
to
care of the
be-
circ.
The only way you see circ could was RAO, little bit.
Hmm.
AP,
Yeah.
AP or RAO.
Yep,
You want to take a picture here?
yep, yep. Or, yeah.
Yeah.
Guide is a little out.
Yeah, I know. I want to just keep dancing. Okay, ready?
Hmm.
Will, what is that on the?
It's still damped. Very
Huh?
good. So now, okay, let's
There's
go to
that
the caudal. Yeah.
diag, about 2 to 5 size. We never wanted to pay attention to that. It's growing up in size. We try to advance. See
Quite
that?
damped.
Yeah. Okay, ready?
Yep.
Okay, we'll wire it and then do an. You want IVUS of the circ or no?
Okay. So let's take opinion with Abhishek and Arindam that you will do a direct now. Should we just go ahead and use a cutting balloon, or if should we already have a 1.75 bar and use that also in the circumflex? So that's the issue.
Sir, I don't see a logic in doing IVUS in SIR because we can see clearly the calcification which involve the LAD that is also involving the SIR proximal part. So it will be definitely a hugely calcified vessel. So I think some form of debulking, either if IVL balloon goes or some form of debulking will be good for the patient.
Okay, good. Agree. Yeah. Put this. You want to put this rotawire in the circ?
No, I just wired the LED.
Yeah, I know. But how you want to do
What?
the circ?
Circ, we get the fielder wire.
My question is IVL. Take the rotawire out. The question is IVL versus cutting balloon, knowing that quite calcified.
I think for
in this
2
one.
quadrant, we should be able with the cutting balloon, no?
Okay. So what we'll do is we'll change this wire. Tip.
Mm.
No, that's okay.
For recross. Hold on.
Yeah,
Let me try this.
Yeah. Okay. 3O. Wolverine. So we are going to use a 3O Wolverine at low pressure, and let's see it opens. Otherwise, IVL ready. Get IVL ready. Also, I think circ is 3 millimeter. Agreed?
Yes, sir.
Yeah. So 3. Yeah, this wire was originally used a little destroyed tip. So we can use another fielder wire if need to be.
Yeah, I was trying to use.
Or you want to run through a fielder?
No, fielder.
Yeah, that's okay. Good. Good. Okay.
We need a new fielder to recross after we stent it. What did we say? We are doing IVUS? No, right?
No, we're doing a cutting balloon here.
So we're going up with the 3O Wolverine to the circumflex. Do you want to dilate the LED?
And I try to say that circumflex is the one very notorious for a bad dissection or perforation from the rotablation. So unless it is absolutely necessary, avoid it. We actually did one very complex case. No, but we are not. We are saying we may or may not use. Huh? It's a bag only. We did not open the device. Yeah, okay. Good.
Okay, good.
Okay, yeah, good. Yeah. Okay, they are getting ready. Or my team is very confident that we are going to need IVL. So they are ready with IVL.
Go.
But I think we'll be okay.
Yeah, it's okay. You see that? So how you know that it has been taken care? Okay.
But there's definitely a lot of calcium.
More of it is adventitial calcium. Yeah. Good. Go up there.
Yeah. The question is that do you want to do IVUS now?
Okay.
We still should do IVL. I mean, based on the calcium and expansion, we can supplement with, you have to go a little further again. Yeah. In the circ. And you go with the Wolverine, you can go 16, 18 atmosphere without any problem.
Go up here.
Yeah. Pull back and go to circ again.
Okay.
So this is the ostium we are doing now. 18
Ostial
atmosphere.
left main, done. And we'll go back into the circ.
Yeah.
Okay, good.
IVUS is ready?
Yeah. I don't think you need IVL.
Okay, let's see.
Fully
Yeah,
taken care. Okay, go back here.
yeah. I personally think it's not needed to.
Yeah.
But yeah, there is a lot of calcium. You see that.
No, it's mostly adventitial
Yep.
looks like. Good.
I think it will be
do
good
the
to see.
OCT.
Yeah.
I mean, sorry, IVUS now. Come.
Good to see the superficial calcium. Good. So as we discussed, that we are done, modified the ostial, proximal circumflex, and just confirming with IVUS that we have good lumen, crack in the calcific plaque. So any questions from our audience? Will they do any different? And again, as we said, that based on the complexity that where two stents should be used, this will qualify in that. Yeah. Or even the definition two criteria, both. Okay.
Yes,
Start.
start. So this is I think this is a reference. Looks like healthy, and some branch comes here. There is one quadrant, two quadrant of calcium, and yeah, I think this is much expanded than pre.
Fluoro, where we are now.
Distal left.
And
No,
coming
it's in the
to-
left vein.
So you saw that calcium was barely less than 2 quadrant.
Yes, sir. And
Yeah.
the lumen which you got is also very, very optimal.
Very good.
I don't think
Yeah.
we need
Yeah,
IVL
exactly.
or something.
So no IVL, guys. IVL machine can be put back on the shelf.
Go back. Go
Yeah.
back and park it.
Okay. So now you need to modify with the same
LED.
balloon. I think we can do
LED.
or 3.5. You need 3. We have 3.520 also, or you want to just
Oh.
do the same?
Oh, high pressure. Okay,
Yeah.
then give it.
Huh?
High pressure.
Yeah.
Just a
Let-
question.
Yes.
Would you have considered a provisional approach in this case?
Well, I mean that's that's a very good point. Yeah. So the whole concept of bifurcation lesion, whether you do a provisional, stepwise provisional, which was shown in the EBC one, but otherwise we actually even original bifurcate app for the left main when you involve both the branches, we never had even single stent. We just had a two stent, mini crush, DK crush, or culotte. So this case, I would say there is no reason. I mean, there is no reason to go with the one stent because very high chances that this patient will require two stents. Means the side branch stent. So therefore, it's better. Ready?
Yes.
Yeah. So it's better that go with the classical two stent approach because we all know when you do a bailout second stent, it's more troublesome compared to a planned two stent approach. Yeah.
Down.
Negative. So I would say that, you know what, go back to the slide. I want to go, this is a very important point. Show the slides, please. Okay. Yeah. So we are stopping right now.
Go. Go.
Our bifurcate, we'll show that bifurcate app also at the same time. Yeah, so this is the one. If you go to the simple left main and complex left main bifurcation, main vessel, side branch, more than 50%, length more than 10, and as you can see here, that calcified, both are calcified. So their chances, remember in these cases in the DK crush, 46% require stent of the side branch. And I would say the DK crush data were unfavorable for the single stent crossover because such a large number required two stent approach. So go plan in these cases, which is the complex left main bifurcation like this one, that you are going with a two stent approach compared to the simple. Once the simple left main bifurcation, provisional stenting is perfect. And therefore, this case, in my opinion, otherwise also we have very low threshold of putting two stents for the left main. Yeah. And therefore, it's a good for two stent approach. Okay, we are ready to take a picture. Now we can go back to the angiogram. Good. Okay. Which is disrupted, very good.
Yeah.
Yeah. Which
Okay.
stent you want to do? There is a little bit of disease in the, I think that's a spasm more.
Which one?
LED further down, right? At the septal level.
Oh.
But we
You
never
mean
did
the
anything there.
lengthwise?
Yeah.
I mean, this balloon might have done that. So, but what length you want then?
So I think the LED is the long one. we get a 3.5, maybe 38, and
No, 38 may be too long.
okay, and then
32.
30,
Oh, this was 20. You see
20,
that?
yeah. You have to come up to the septal. No, you had to come up to the septal. So 38. 3.5, 38, and 3 point circ branch was what?
30.
30. 30, 12,
No.
or 16?
Minimum 16.
16. Okay.
You have to cross that OM branch.
Good.
Yeah.
Okay. So let's get those two stents.
First, give me the circumflex stent. 30.
Yep.
16.
So agree with that. The long coverage, because LED disease is still there at the level of the
Come up to the
septal.
ostium.
Yeah, see this? There's always a disease up to the septal there. Yeah. And clearly, every time we get
3 or 16?
Yep. So we're going to cover up to the septal. Yeah. And first, same with the, now they can go back to the
Mini crush.
slide of the mini crush bifurcate 3D. They can play now. Go. And so first you go prepare the lesion with the rotational atherectomy of the LED with the high pressure PTCA and of the circumflex by cutting balloon, modified or scoring cutting balloon. And so then now we are going with the stent in the circ first and then stent in the LED. So mini crush technique 7 French guide. That's one approach, and I would say I would not say the provisional stent approach in this particular case, and largely because of the complexity of the left main. We have very highly likely chance that we are going to require 2 stent approach there, or means bail out in all 30-40% of cases.
Get me a new fielder.
Okay, good. So placed. Let's go to the second one. Now, are you using the Miras 100, the bioabsorbable stent in some cases?
Yes, sir.
Yeah.
Yes, sir. We do have some experience with that, though it's not very common stent to be used.
Yeah.
But yes, we have used in our center around 20-25 cases.
So actually, I have been same experience I have, that it's doing quite well at present with the 100 micron. Original 10-12 cases which they have already now the follow-up. We have shown quite good results. No issue with the stent thrombosis, which used to be with the old absorbed stent. We had a good promise. Okay. So key is that.
Take a picture?
Yeah. Let's take a picture. The LED may require additional one. Let's see. But we have to come up to the ostium.
Go.
Yeah. You have to bring back. No, that's fine. Yeah, you can bring back 2 millimeter.
No,
You have to come to the ostium. Yeah. Huh?
Ostium or what?
Of the left main.
That's we can fix later. I'm just looking at the circ now.
Good. Yeah. Ready? Circ is good. Okay.
Another view? No?
No.
Okay.
We are going into the circ now.
We are deploying the circ stent. We have at least a millimeter sticking into the left main. That's what we want. Fully deployed at 14. Good. Okay.
What stent was this, sir?
16.
Yeah, it's a Promus Elite.
Okay.
Yeah. Question is synergy,
Some dye.
particularly with the ostial left main. We are a little concerned unless you use a synergy Megatron.
So now it looks okay. I took the SDS and then the wire out. Now we're going to adjust the left main.
Also. Both. You can take both of them out. This we don't need.
No, I don't know why.
We have to put a different wire because wire is usually you can use the same wire, but this wire was damaged. We knew it.
Okay, now to make sure the ostium is involved, you want to go to cranial view, right?
Now we need to have full cranial, full coverage of the ostium, so we'll go cranial.
LAO cranial, sir?
Yes.
AP,
LAO,
LAO,
yeah.
RAO,
But anyway,
whatever.
yeah. Or LAO. LAO actually is the ideal one, but the AP also in this particular case showed it
Yeah,
earlier.
give me some dye.
So we have that.
Yeah,
Yeah.
I think AP is good enough. I'm going to pull back a little bit.
But yes, the board question always have been that LAO versus RAO cranial. So they'll not give the choice, but aleocranial is a very good one for the ostial. Yeah, take a cine. Yeah, very good. Okay, we're going up now.
And hold on. You want to pull back a little bit?
Want to bring 1 millimeter back? There's enough room.
Yeah. Okay, and pull back a millimeter back. Yeah.
Good. That's
Okay, good.
Going up.
Okay. Don't go too high. Are you
Ready?
going up? Yeah.
Okay. 10,
12. Enough.
12.
Down. Now here, since we are up to the ostium, we have to be very cautious when we are now getting the engaging the guide. With the balloon there, maybe I'll just engage the guide over the balloon because the risk of LSD. Done twice. So if you see here, I'll just
And
engage
get a
like
4012
that,
or 408.
and then
8.
remove the.
Yeah, good. Open the ostium a little more.
No, later on.
Okay.
If I do that again,
And for the
guide
pot,
will come
we'll take
out.
a 40. Left main size was what?
Okay, take a picture now.
4.6.
4.5. Okay.
Yeah, sorry.
No, it
We'll
did
take a
not look-
4.5, then 8
no,
or
no,
12.
take a 4.
Good.
You don't see any damping now.
Yep. We go back to other view.
Yeah, go to the caudal. Dag is okay. And there was that OM also which we have jailed. We have jailed 2 branches, DAG and a small OM also.
Good. So let's cross again. Let's see this view. Ready? And see no dampening now. That means you have full coverage. Good.
It's very good actually.
Yep. Give us a
Okay.
3012 high pressure.
So now again there is always a question when you want to recross before pot or after pot.
So if there are no side branches, I think
Nothing.
I'll go pot first followed by recrossing. Because there are no wire kept at the side branch.
Agree. We need a 3012, right?
Yes, sir.
To the circ. And what we have a 40? It's too much. Okay, get us give me a 458 first.
This one high pressure will go into the circ.
We
Right?
should have taken a longer because the left main length is longer. We
No,
only
that's
have
okay.
a 8
What is this
millimeter.
now?
8.
No, but have we done the ostial circ? Or you want to pot first? Okay. So question is always pot, then kiss, or repot, all those things. So we'll do the pot, and then we just do a kiss. So we actually have done in a non-left main bifurcation lesions.
Okay, go
Ready.
up here.
That kissing versus pot.
Go up.
Actually kissing did quite well, and that was in the pot pro trial also. You
Down,
have to
down.
pull back a little bit.
Okay, I will.
Yeah. So we dilated 4.5 at there. It was a little more than pot
here.
here. Yeah, this is it. So there we'll go 4.5, 16.
Down, down, down. It's not.
He said 4 point here.
Never go
Ostium a
to
little
here,
bit more.
this, I'm coming up here to the.
Good.
Now you do it. Yeah.
Yeah. 16, 18.
Okay. So this is a true left main ostium. Now give me the circ balloon. No, you want another one to the LED, right? Another balloon to the LED.
We are same. Or 3.5.
Okay, give it to me.
Yep. We are 3.5. So now the question will be that after we go to the circ, We go back. So how many people will do the report? Or will be enough with a kissing balloon? So I think that we can ask the question to our audience also, and how you will do both
In this kind of
Bond and
left
rod.
situation,
Yeah.
yeah. In this kind of situation, after kissing, if we do a final report, that will be completely acceptable. I think I'll go with report, final report, because you never know the stent, as you mentioned already, the guide is the EVU guiding catheter, what it is doing to the proximal stent.
Yeah. So what we do is, we quite a bit we use this our Mark 1 guides of the Boston Scientific. This is a VL, very soft tip. So EB,
Okay.
yeah. So they, but yeah, you're right. It doesn't matter. Any guide at the ostium can create the trouble. Get the other one also. Yeah.
We will show you after kissing with imaging that there's no need for report,
Yeah.
but it's
We have
very
done-
it's very difficult to convince the, I would say, the world.
No, because all goes for the European
It is-
bifurcation
yeah,
club.
They somehow have put this thing without any data. Everybody needs this pot, kiss, report.
Yeah.
Probably, sir, the shape of the proximal left main after a report is slightly more circular as
No,
compared
where,
to
where are you getting that from?
No, but that's remember, this is just the expert opinion.
Yes,
Nothing is published.
Nothing is published. There's
Yeah, but
no
you're right.
there's no imaging data, and what they're showing was done in vitro.
Good.
right.
Yeah,
Ready?
but people like it.
Good. Just pull back. Good. Ready?
Yeah. Good. Don't go too crazy number.
This 3-0.
Okay, I know.
Good.
Okay,
Go
go.
up.
12.
But you have to go more in the LED first.
Okay, good. Okay. Down. I'll go just LED.
Yeah. Go LED further. We have to open the LED still more.
IVUS is ready?
Yes, ready.
Okay, go up here. That's good enough. Around the distal is good. Yeah.
Yeah,
Go
yeah.
18. 20.
It's a
Yeah.
3.5.
Yeah. This 3.5, right?
Yeah.
Yeah, good. Down.
Yeah.
Okay.
And then bring both of them to the ostium.
What is this?
Good.
I don't think
Right?
we need that. No need.
So this will be your modified part.
No, please.
The two
Don't
balloons.
teach something that is.
Yeah. 2 balloons together. So,
Yeah.
Flora.
Just forget this step happened. Yeah.
Yeah. Yeah.
Now the IVUS will be altered.
Close your eyes, please.
No, but that's what I call this as a modified pot.
So just to expand the discussion, Madam also.
Yes.
We call mini crush, and you tend to prefer mini crush in a lot of your cases.
Yeah.
What is the difference between DK crush and mini crush as per your experience?
Okay, so
Why not a DK?
yes, I like it because one, remember the DK crush, all the trials have never been done outside of China or never been shown. DK crush never ever compared to mini crush technique. So only one good thing about a DK crush, what everybody says that we cannot argue, is recross. Means what they say is that since we are already, you are doing the left side branch stent, you are going to crush it, 2 layers of stents are there, you cross at that time and you're creating a space. Since you're doing a kiss, you're creating a space that recrossing later on is much easier. But you guys have seen our live cases and Mount Sinai does the majority mini crush. Between the two of us, we probably have done over, how much would you say, 10,000?
No, but
Bifurcation,
not,
bifurcation.
Yeah.
Over
the
these
years.
over the years.
Yeah. For the left main, less, but over the mini crush, the key is, so just to simple way.
So that way, what I meant, no matter what trial, what they say, you cannot beat the experience.
I was pleased.
Yes,
No,
sure.
Yeah.
Pull back from the interest.
No, but they have to bring the IVUS on the screen. Yeah.
Yeah, this is a stent well
Yeah, good.
expanded, well opposed. Yeah, there is some calcium outside the stent, but the stent is well expanded.
Yep.
Very circular expanded, and sock comes here. This is distal left main. and also well expanded. Oh, sorry, this is Circ, sorry.
Yeah, yeah, I know.
Yeah.
So I'm now in the left main.
Yeah,
Come up
Now
to
in the-
the ostium.
yeah, now come to the osteo. Very circular.
Good.
And stick to
Now you see that how circular it is.
We can go back. Yeah.
Yeah.
So question is, so this is the point we wanted to make, that the kiss you cover there, so no deformation. So coming back to simple, I would say what is against for me DK crush versus mini crush? Very simple, extra steps of the DK crush. So do you pay the price that you cannot cross the side branch? No, we never had the trouble. And
No,
we have seen it.
exactly
Take the
what I
wire
was
out.
trying to
Yeah,
tell them,
yeah.
that you have seen. Now you
Yeah.
can say that we are so much experience and all these things, but you also will get to that level if you master
the
in
wires
one
out, yeah.
technique and keep doing the same thing.
No, but they do quite a bit in India. They do a lot of DK crush.
Yes.
And nothing wrong with
Of
that.
late, we have also,
Yeah.
of late we have also started doing good number of mini crush as well, sir.
Yeah, because I can tell you, you take so many steps away. At least 3-4 steps away from the mini crush, and of course the DK crush, the whole science, whether you go distal strut, side branch, the proximal strut, and all those things. So a lot of theoretical points.
Let me do the circ of the, IVUS of the circ.
Yeah, and do the IVUS sir.
Sure.
So question comes is, when you are done the pot, we fully agree pot for the left main.
And
do not-
the reason for pot in the left main is discrepancy. 3-0 circ, 3-5 LED, 4-5 left main. So you definitely have to dilate the stent. Since we placed a 3-5 stent, you got to go to 4-5. That is totally understandable. But other extra steps that we are saying, circular versus oval, it has not been shown. Circular versus oval is that person's vessel, the patient's body vessel. So the stent is going to take that shape. And in the non-left main, I think we are going to show you the slide, the work that we have done with imaging as well as the flow work that we have done, that no difference, kissing versus just doing a pot in these cases. And say multiple steps, you are going to wire multiple times. Sometime the wire can get crisscross, So try to do complex cases with fewer steps and come out with good results. That's what we should be
Yeah,
aiming
start
for.
IVUS from here. So this is outside the stent.
Yeah.
Still outside. Now stent comes. Yeah, there is no dissection at the distal edge of the stent.
Now,
And
if you're telling me that yes, I have done DK crush over and in the DK crush trial, remember DK crush trial, they had to do over 25 cases and show it to the PIs before they can say yes, these are the operators. They had to do more than 100 left main PCIs before that. So they are talking about a lot of experience before you can do left main DK crush technique there. So they only picked good operators so that they know, or experienced operators, to say that this technique can be done by anybody and everybody.
Madam, in your opinion, have you faced any difference in recrossing the crushed stent between DK crush and mini crush?
No. We are biased. Let me say before I say no. We do mostly mini crush. We mostly do mini crush. We have been doing what's called as a step crush, that sometimes we go with 6 French radial and things are not going easily. We can just deploy the side branch, then crush it and then put a new stent. Where we really face a problem in recrossing, if there is heavy calcium. If there was heavy calcium in the left main, ostial LAD, ostial circ, and we did not do a good job. You know us, you have seen how we are insisting on plaque modification. So we will do atherectomy, if a cutting balloon, and now of course IVL if we think the balloon has not expanded very well. In those cases, we have had trouble where whether it is left main or non-left main, heavily calcified vessels, recrossing the side branch could give us trouble, because the calcium itself could be an issue when you're trying to recross the side branch. Otherwise, your 2-layer or 3-layer of stent with the current type of wires that we have should not be an issue.
And your choice for rewiring is, ma'am, fielder
Yeah,
wire?
what we use fielder. Majority of the cases fielder, same. It is polymer jacketed and it is hydrophilic coating. So getting into the side branch is much easier. You seen this, we even trap. Suppose we are doing provisional, we use fielder and we trap the wire in the side branch. Nothing happens. Though there are studies to say that if you use polymer jacketed wire, that when we are removing the wire, that some of the coating could get stuck. But I guess it's okay. We are leaving a big metal, little coating is okay to be in the vessel. That's one. Easier to remove from the side branch, but if you see any resistance, do not keep I would say pulling the wire. That can break. Usually you see that more with BMW run through and all that if they are in the side branch. If you see that it's not coming out, take a deflated balloon, go all the way up to the ostium of that side branch. So now you have a better rail and then you start tugging or taking it out. That's how it'll come out. Yeah, that's a technique for the jailed side branch wires. So we did, what's the sir cross-sectional area we have?
5.9.
Okay.
Yeah, at the OCL.
Left main?
Oh, this is OCL Circ, and
Left
for the
main?
left main we have 10.5.
And LED?
And LED we have 7.4.
Good. So I think we meet all the numbers. Anything above 6.5 for LED, 5.5 for Circ, and above 7 for left main. So I think if everybody okay, I'm going to remove the wires and take a final picture. So any other questions for us? Some
So in a
vasodilators.
country like India, resource poor country, if we use mini cross, actually good number of balloons can be actually avoided. So for DK cars, everybody will agree probably the number of balloons, hardware's requirements are higher.
Yeah, maybe that should be your next propaganda. So remember also our center is very big in training. Right now, you see my fellow Udit, he will do this entire case by himself if I leave him alone here. So we allow fellows to do a lot. So we are very careful in what the techniques have to be. So they learn all these things from us. He's now in the final stages of his training. All these complex things they do by themselves with us in the room. So we are allowing them to do these things. So we have to have fewer steps for them. So if you see the diag flow is still there. Yeah. So OM flow is still there. EKG, can we show the EKG? No damping. You see that? Which shows that no chest pain. Is feeling good.
Ma'am, for operators with somewhat less experience who are attempting the mini crush technique, say if they face some difficulty in rewiring, any tips for what might be done?
Okay, so you're talking for the left main versus non-left main. So in left main, remember, if somebody argues or tells me I would do pot first, that's okay, that's acceptable. I will go with it because you have the left main. Now we put a 3-5 stent, right? So we are trying to wire, so you may be going underneath the stent strut. So to make sure you are in the lumen, you understand? This is how your left main is. You place the stent. You want to make sure you're going in the lumen. So of course, with the experience, we know we are going in the lumen. That's why I never did the pot here. You see that? But if that's what you want in the left main, do the pot so you know now the stent is fully opposed. That's one. Also, the stent could expand and then you will be able to get into the circ better. Fully opposed and so you want to do pot first, that is acceptable with the wire. Right now people will also tell you maybe go to the LED, coming back to make sure you're in the lumen, and then just twirl your finger. How you train yourself, we always say, is that your thumb and your fingers, this is the way you have to be working on that. This is what should be your movements. Okay, that is how you're doing. And when you're turning like that, that's how you get into the circumflex, and you keep moving like this way. You see that this way, so the tip keeps, so the tip has to listen to your fingers. That movement can then find, okay, this is where the opening is, and you go down. And this is why I'll never understand proximal strut, distal strut. You go to the optimal strut. Means if I can get a strut and my wire goes, I'm happy, right? Now, how are we going to confirm proximal distal? Again, you have to do imaging. So we are adding too many steps for all these things. But you have seen the same thing we have done with the final imaging. Look, that looks so good. So that's what I would say. How you have to get into the side branch.
And most important is, people always worry about, what if I am the behind the stent struts? So what clearly I said, go to the distal vessel, LAD first, and then pull back. If you're behind the strut, you cannot go that far. It will be resistance. So goes clearly there, and then you pull back, and then you go to the circ. So let me show you one slide, which we did published 2 years ago. Okay. Go to the next one. So we did, so just to answer with the pot versus KBI, it's a OCT. And take this main vessel and proximal and distal. And basically the blue bar is the minimum stent area, and the violet or the gray, brown is your percent mal-approach struts, and KBI and pot. And you can see there, let's say main vessel. Look at the KBI, the lumen, definitely you got better minimum stent area compared to the pot. Second, look at the mal-approach struts, significantly higher as well as in the proximal segment. In the pot, you had a lot of mal-approach struts, 5.7%, while 0 with the KBI. So just to say, people have underplayed KBI without solid data. So this is our OCT analysis. You see there that with the that overall, that with the lumen is very significant. Now, once you are distal, the pot or KBI didn't make any difference, although still the lumen always was a little better. Now, people say, well, maybe it's not a circular lumen, it's a little eccentric, but that's okay. But more important is percent mal-approach struts. That is what we know creates a trouble. And you can see mal-approach struts definitely are much higher with the pot in various settings compared to doing the KBI. We can go back to our presentation now. And I think we'll be concluding soon anyway.
Do you
Yes.
have the other slide? Yes. Any questions?
And the question was, in this case, should we use any assist device, balloon pump, ECMO, PTVA, or Impella? Next, we have the protocol, complexity, and LV dysfunction. And basically, I think it is the more so is the ejection fraction. So people, there are some data now that even with a normal EF, you might need a balloon pump or Impella like this case. If this case would have been RCA total with that left main, doing the bifurcation, I think it's reasonable to use balloon pump or Impella. But since RCA is good and EF is about 50+%, I think this is the case which is in the middle, which is the 20 to 40% EF, complex PCI. And right now we have an ongoing trial called Protect 4 in that. And Protect 4 basically is standard of care where you use a balloon pump in most of them, and then versus Impella CP. The trial is ongoing. It's like 18, between 12 to 2400 patient trial based on the event rate, and it's the target vessel failure. It's a clinical trial. The minimum 2-year follow-up, and the trial actually 100+ centers. I think there are 350 as of last recall. 350 cases have been done. Sinai actually one of the top enroller with 40. So we have more than 10% just from Mount Sinai in these cases. So key, yeah. And the key is the DK crash. There was people say, well, I want to do DK crash, but if you go back to the DK crash, they actually had a very clear-cut criteria who should get what experience they have. It's quite a bit. But compared to our mini crash, anybody can do it. As long as you are careful that your wire is not going into the behind the stent struts. You went to the LAD, pull back, and went to the side branch. Yep. Want to share? Anu, you want to say something?
No, the endothelial shear stress, that slide.
Yeah, we have that.
Yeah.
You want to show that?
Yeah, what's the question?
Yeah.
The question is, would the angle of the LCX make
Yeah.
you change your strategy from mini crush to something else? This is by Dr. Sandipta.
I think I would not. What would be the other technique that you're talking about, culotte? If your angle, right, angle of the circumflex, I would say the most difficult would be a retroflex, right? Your angle,
Yes.
retroflex, going backwards. In that case, no matter what technique you want to do, getting a stent into the circumflex will be way harder. So whether you're doing mini crush, DK crush is the same. Suppose you tell me, okay, since it is a retroflex, I want to do culotte because I will go from left main to circ and then I'll put into the LAD, may be acceptable, but you have to remember in culotte, now you have unnecessary 2 layers of stent, no matter where you place it, whether you want to cover the full left main or you want to leave it in half of the left main, there is 2 layers of stent in the left main with the culotte. So, there's nothing, retroflex, circumflex itself is hard. I think once you think that you are able to get a balloon or anything else, whether you want to do DK crush, mini crush is acceptable. So the total contrast was 120 cc with the depth of 0.4 for this case.
We have another question, ma'am. This is from Dr. Ajay. He says, recently I saw a case, acute anterior wall MI, angio, LAD ostium 100%, large ramus 80% ostium, RCA 100%, mid CTO. Patient having severe left ventricular dysfunction, 25% ejection fraction. Should PTCA be attempted? Which vessel to address first, LAD or ramus? LAD ostium was 100%. Ramus was a large vessel with
90%.
Ostium.
Yeah.
And
So
RCA had a mid 100% CTO.
Yeah, so this one all depends to what is the EDP of the patient and EF. EF was what, 20-25%?
25%.
Yeah, so I mean, if you have access to Impella, this is the case depending on what with that, if LAD is total, RCA is total, then the EDP would be very high with this particular case. You would go with upfront, you need some kind of support. Now, if you don't have access to Impella, that's okay, go with the balloon pump. Now, MI depends. When was the presentation? If it is old MI, means old, we are talking 2-3 days, is different. If it's an acute MI within 6 hours or something, you will still attempt the LAD. Once you have a flow in the LAD and your wire is there, then you can decide. Maybe you can just balloon the ramus and just stent into the LAD ostium to the ramus, rather than when you are in the acute setting and there's a lot of thrombus, try not to do bifurcation and complex PCI, because the risk of stent thrombosis, if you are doing two-stent, crushing it with the low EF, the stent thrombosis rate is very high in this setting. So try to avoid that. In that case, we will balloon, whether you want to do simple balloon, cutting balloon and stent across the LAD, but culprit vessel should be the first one that you need to attempt.
Say, ma'am, if it would have been not an acute case, how would we have approached it? Plan for a bifurcation right away?
No. If it's not an acute case, of course, if the syntax will be very high for this patient, you get a surgical consult. Of course, they'll say, I don't know what is it out there in India, what they will say. With that low EF, will they say yes or no? Means will the surgeons take the case or no? In that case, definitely you need a support. It's a chronic total occlusion of the LAD versus RCA. Then you want to attempt LAD, has to be attempt LAD. You'll never take care of the ramus first, because you'll take care of the ramus, you may then dissect, you want to put a stent, then your attempt for the LAD and doing your PC of the LAD will be way harder. Yeah. So you still would want to attempt LAD first. Okay.
Yeah. And so go back to slide. You wanted to show about the shear stress in the same data. But this was verified more for the OCT.
No, this is OCT data. More for no, this is.
wall stress, but that was not exactly in the bifurcation. It was part of the same presentation. So we also found that there was more shear stress in the with the
Where is that
bifurcation compared
slide
to with the
with
pot. So with that note, okay, But anyway, any other question left? Let's go back to the questions now. Anything left? Yeah.
No, all
Question?
questions
All right.
answered.
Perfect. So let's start your case presentation. I'll join you in few minutes and thank our Mediquest team and of course both of you, faculty and moderator and all our audience for this lively discussion. And thanks from Mount Sinai Cath Lab. And of course our staff, usual faces, all our fellows. And so Udit and Rajiv Samtani are two fellows, right? You can see them or no? They're somewhere, yes.
Yeah,
Okay.
you can clearly see
All
that.
right. Thank you.